for September. For those of you who are able to join us at the annual general meeting this morning, lovely to see so many of you on the call. And in terms of today's meeting, I'm delighted to welcome Jim Sinnott and Liz Coles as our two new appointed governors. So welcome to the two of you. Great to have you on board with us. We have apologies from Harcomel. So Sally is standing in for Harcomel for the Cancer Services update. So thank you, Sarah. And we've got Ellie Ward, who's deputising for Fiona. So Ellie, lovely to see you again. We also have our three new associate NEDs, which will be considered as part of the body of this meeting. But it's lovely that Ollie and Barty are able to join the public meeting. Oliver Collier has to send apologies. So today is obviously an extremely busy day for us with not just the annual general meeting, but arguably operationally more important is the joint industrial action. So I will be keeping things moving forward to try and free up time for the executive directors to do the all important stuff of trying to optimise the service we can give to our citizens in what is a very difficult period for everyone in the trust. And I would like to thank everyone who is attending work today, is having to put in the extra hard yards of looking after our citizens. We are effectively offering a Christmas Day service, but the demand is the normal level of demand. So that puts our frontline teams under a phenomenal level of pressure. So in terms of declarations of interest or qualifications of office, is there anything colleagues would like to raise? Could you please put up a digital hand for me? Okay, super. I think, Sarah, can you just confirm that Glenn and I's register of interest has been updated for our involvement with Worcester Acute and my ownership of Maranatha One Properties Limited?
I have, and it's available on the Trust website, Russell.
Super, thank you very much. So the last set of minutes of the meeting held on the 11th of May. And sorry, we also do have apologies from Simon Page and David Spraggart, who is having to look after patients in his old surgery today because of the busyness of life in the GP land. Jane Knight, could I ask you to turn your camera off for me, please? Nice to see you. Mike, did you have a declaration of interest? Mike Wells, you wanted to raise?
No, it was the minutes that you just started to introduce, and then
Okay, Mike, I'll come on to that, just bear with. So the last set of minutes held on the 11th of May. Are there any points of accuracy colleagues would like to amend? Mike?
Hi, yes, the May meeting approved the minutes from the February meeting, which I was noted as being absent and reporting at. I was actually there. I think me raising that enables Sarah to fix that in various places now, because I've spoken to her about it.
Okay, super. Thank you very much for that, Mike. Any other points of accuracy from colleagues? Please raise a digital hand. Mike, if you could take your hand down, that would be helpful. So in terms then with that amendment, if you're not happy for me to sign them, please raise a digital hand. Okay, thank you. I will duly sign them. So in terms of matters arising and the actions update report, we go to page 24 of our pack. And I think all of the items for these have been picked up. But an action in progress is for Fiona to provide a more detailed narrative in her next report, which I'm sure she will do. So are there any matters arising that colleagues feel have been missed out of that action log? Please raise a digital hand. Okay, I can't see any digital hands raised, so we'll move on then to the chairman's remarks. It is an extremely challenging time for Swift at the moment, as I said in my introduction regarding the industrial action, but I'm absolutely delighted at the way the team have responded with agility and focus to ensure that we do optimise our performance for the citizens that we serve. Since our last meeting, Worcester Acute have joined the foundation group, so Glenn and I have become the chair and chief executive over in Worcester Acute. For members of the public who maybe haven't heard me say it before, in my view, this is an act of enlightened self-interest for Swift, because increasingly Swift has been having to help out Worcester Acute's emergency department, given the challenges of flow they have over there. And so over the next 6 months, I am expecting some of the pressure from those transfers from Worcester Acute to be alleviated. So I'm optimistic about the impact on Swift in the medium term. Michael Coker, could I ask you to go on to mute, please, and turn your camera off? But things over Worcester Acute, like a lot of the rest of the NHS, are extremely tough at the moment. And in that context, I think Swift is performing remarkably well. In terms of our integrated care system, I'm sure Glenn will pick up on greater detail on this, but we continue to work collaboratively with our partners, often in trying circumstances. But I'd like to put on record the fact that Dame Stella Manses is standing down as chair of UHCW in the next few weeks, and I would like to thank Stella on behalf of us at Swift for her hard work over at UHCW over the last 4 years, and we wish her well. So if there are no questions on those remarks, if there are, please raise a digital hand. Michael, we're still seeing you in your full glory. If you can try and turn off your camera and go onto mute, that would be wonderful. I know that is sometimes not the easiest of things to happen, because we often see you leave the meeting and come back, but good luck. So we'll move on then to the assurance items, and the governors have asked for certain items of assurance. The first is cancer services. So Sarah, can I go over to you for your update and overview on our cancer services and the challenges that we've had? Sarah.
Okay, thank you. So obviously cancer performance still remains an issue for the Trust. Since 2019, to put it in some sort of context, we have seen an sustained increase in number of referrals coming into the Trust on the suspected cancer pathway. June this year has actually been the highest number of referrals we've ever received in 1 month, ever recorded. And that level of referrals has been quite sustained now for the last sort of 18 months, 2 years. On a positive note, though, there is a national standard around diagnosis from the time of referral to confirmed diagnosis, and we have 28 days to confirm either somebody has cancer or they haven't. And the national standard is 75%, and we have made some significant progress in actually meeting that. And certainly during July, August, and it looks like September, we've exceeded that 75%. So although our referral numbers have gone up, actually diagnosing patients within the 28 days, we are now meeting that national standard, and we've put things in place to make sure that we sustain that. We've still got some work around some of the other standards about getting people in for treatment within the 62 days, but certainly that is a significant step forward from where we were probably 12 months ago. The other thing I would like to highlight, which is in the report, is chemotherapy care. We did have some issues with access during the beginning part of this year. That was a couple of things. First of all, it was staffing in our pharmacy, the people that actually make up the chemotherapy drugs. And there's been a significant amount of work in there to recruit staff into that and get them trained. And actually we are in a good position again now. So we're back to the service levels that we were seeing previously. So there are no delays once somebody has been accepted to take chemotherapy as treatment. We're still working on shortening the waiting times to a first appointment with a consultant before we even start treatment. We work in partnership UHCW provide those consultants for us. So we are working with them to reduce those. But again, we have made some significant progress. We're down to, I think the longest wait at the moment is around about 5 weeks, which is incredibly, from where we were. So we are continuing to work with that. So from that end of the pathway, significant work. So I just wanted to provide some assurance that once we have diagnosed cancer, that actually starting your chemotherapy, we've reduced those waiting times significantly, and we're almost back to normal service now. And that really is just the highlights, and I'm happy to take any questions if anybody would have any.
Thank you, Sarah. And, as you've said, and as Harkamel says in the report, we are acutely aware of the impact and anxiety these delays have on patients and family and loved ones. Yeah, so we are very, very focused on this. Any questions or perspectives to Sarah? Okay, I can't see any digital hands raised, so we'll move on then to the next item of assurance. Thank you, Sarah. The community bed review. Adam, this has got a little bit more complicated than we hoped. Adam, over to you.
It is indeed. So just to recap, governors will be aware that over the last few years we have reviewed or been involved in a review of community hospital bed provision. The outcome of that review was that, or one of the key outcomes was that community beds were not located in the right places effectively for our population. So the very south bit of South Warwickshire had awfully good bed provision, while up in the north part of South Warwickshire, Leamington, Southam, etc., bed provision was poor, and patients were travelling a significant distance to access those rehabilitation beds. The review resulted in a business case which looked at a number of options, and the option that was recommended from that was closing the beds at Ellen Badger as part of the redevelopment process and relocating them to the Leamington site to enable them to be closer to the population they serve. As part of that, as a trust and as a board, we also took the decision to increase the number of community beds, recognising the operational challenges and the increased demand on services. Now, this is a recommendation we make as a trust. It's a commissioning decision, so we have to recommend that to the ICB. We sent that recommendation and the case behind it to the ICB back in March, and then the ICB obviously have to decide what to do about it. As a result of that, and as a result of, I think, particularly some of the challenges and pressures from the community, they are considering and minded to go out to a full public consultation on that. In order to do that, they have to redevelop a consultation business case, which they're currently in the process of doing. Now, I caught up with them a couple of days ago to understand a bit about where that's at. And they're currently talking to the Consultation Institute and getting legal advice on the next steps. So I'm not anticipating that case for public consultation will be ready much before Christmas. The consultation will then have to happen and will take a period of time. So I think realistically, we're talking about next summer until a decision is made there. I think that's really disappointed, because obviously we've got staff and patients here and communities without a clear picture of the future, and so certainly we're pushing the ICB to make that decision and supporting where we can. But it's a process we have to work through, and I think it's unfortunate that it's taking so long. But we recognise some of the challenges we're getting and the need to do things properly.
No, thank you very much, Adam. I mean, it is disappointing, particularly as the Health Oversight Committee supported our original approach to consultation. So, but we've made that known to the ICB. Thank you for the update, Adam, and thank you for all your hard work. Any questions on the issue of the community bed review to Adam? Okay, Barty.
Hi, Adam. Can you hear me? Yeah.
Yes.
Yes. I just wanted to ask, given that we're going to be going into winter, is it possible to open up the additional beds whilst we're waiting for the consultation feedback around the closures? Thank you.
Yes, so those beds are, as part of the development work of the Ellen Badger Hospital, we'd effectively temporarily relocated those beds to Leamington anyway. There is some flex in there in terms of bed numbers, and we do use them as additional capacity when we need to, and that's part of our winter plan.
Okay, thank you, Barty. If there are no other questions, move on then to the Operational Assurance Quarterly Status Update Report. Over to you, Glenn.
Thank you, Russell. Quite a big report in front of you today. Apologies that it's so big, but actually when you read through it, some great stuff going on here. So this is the first time you've seen the quarterly status report for this financial year. Obviously, for those new governors, this focuses on the objectives that we've set, that we jointly agreed with you moving forward into this year. And under each of those objectives, we outline a desired outcome and give an update on where we are, and also add a red, amber, green rating. And what you can see alongside all of that content is quite a lot of green, actually, for this point of the year. It's good to see, and it's good to see these actions going on in the context of all the other pressures that Chairman's just gone through. I'm not going to go through all of it, but you'll see in here some big themes, particularly around some of the staff development, recruitment, retention, being a very flexible employer. And you'll see that we are doing a number of things alongside that, particularly recording the requests for flexible working and seeing whether they've been fulfilled, piloting self-rostering in three areas, developing inclusive mentoring, and actually earlier this week I was taught at the 15th cohort of leadership development in the organisation, so trying to encourage people at all levels to reach their potential. And that is also bearing fruit. So when you look at some of our board level performance indicators, we've seen improvements in sickness levels, improvements in turnover, improvements in reducing vacancies through a whole range of methods. And right now we just sent out the staff survey, so the annual biggest survey of all staff in the whole world has gone out across the NHS this week, and we'll be looking carefully to see how we perform. Obviously, those of you who were at the AGM will know we were in the top 5 nationally this year's survey, so it will be it's quite a hard act to follow, but we intend to follow. The community recovery service is also referenced there. I think we talked a little bit about that last time. This is the supporting domiciliary care big move, and that's certainly living up to its promises so far. I'm very conscious that although we green rated this particular area, that we'll only really test this in anger as we get into the winter and see how we meet those particular challenges. But phase 2 of that, which is not only supporting domiciliary care, but also how we link into networks of social support for our patients, is an really important piece of work. Then on prevention, the Excel in Everything programme, which is has been clinically led by Sarah Moppet, who was our interim chief nurse, has moved onto that programme. That programme is not only improving quality, reducing length of stay, avoiding admission, but it's also delivering really big elements of our cost improvement plan for this year. It's a challenge, but we're making good progress on that. Big indicators in there, which Kim will probably talk about in a moment, are around reducing agency spend and doing as much elective work as we possibly can. I'm not sure whether I want to pull anything else out of that. One area I perhaps ought to say is the linked to the work on out-of-hospital services. Yesterday, there was an Integrated Care Board meeting for Coventry and Warwickshire where they've approved in principle a move to install Swift as the lead provider for out-of-hospital services for the whole of Warwickshire. And that's on a slightly expanded remit compared to the current out-of-hospital contract that we hold. And what we'll be doing there is working really closely with primary care networks to ensure that we deliver against the local health needs of all of our individual communities within South Warwickshire. There's then some work on winter planning, reducing our carbon footprint is probably another one I'm going to reference and I won't say anymore, which is one of the issues here for us, and you may have seen this at our last board meeting, is that moving forward with our decarbonisation plans does, in the short term, have a bit of a financial hit for us because the switch from gas to electric currently is slightly more expensive. You could speculate as to whether that will continue, and certainly our view is that this is obviously the right thing to do, but our view is that that will change over time and become financially affordable as well as the right thing to do for the planet. So that's all I was going to pull out of it. Chairman, I'm happy to take any questions.
Thank you, Glenn. Just before we go to questions, quick addition for me. What's your biggest concern at the moment?
One area I didn't actually pull out of here, which is currently going to plan, is the implementation of the new electronic patient record. Those usually get reported by national newspapers when they go into NHS hospitals for all the wrong reasons. Now, I think we're planning that one well, but it's one that needs to be carefully managed, not only just to make sure that we implement it in a seamless fashion, but also that we make the transformational impact on the organisation that we want to, and we improve clinical productivity or patient flow or both as a consequence of it. I suppose we're now at that point where we're starting to look at winter and winter planning. We've seen a slight wave of COVID. We're hoping that huge numbers of our community will get their vaccines this year, and that will help us to manage what's going to be a difficult winter. And so probably, in answer to your question, I'd probably say the combination of those pressures and industrial action are probably my biggest worry at the moment, because I'd like to see an end to the latter.
Yeah, no, absolutely. Thank you, Glenn. I do, again, just want to put on record my thanks to all the executive team and senior leadership throughout the trust and senior clinicians and nurses who are absolutely going the extra mile during this period of industrial action, which is affecting our ability to get the real traction we want and could get on some of our developments and innovations. Any questions or perspectives to Glenn on the quarterly status update report? Mike?
Probably a bit cheeky, but I've always been interested in identifying unmet need in the population, and I wondered if there was any more detail on what you were planning to do or how you're planning to assess that.
That's a big issue, Mike. I mean, if Charles Ashton was with us now, he would be able to wax lyrical on how we don't really understand as a system the unmet need. When you think of all of the volunteer carers we have throughout the UK, young children, fragile elderly themselves who are providing support, the unmet need of the system is, I don't think, anything which has been fully calculated, because the numbers, I think, would be so horrific. Glenn, your view?
Yeah, I think probably the biggest area of unmet need that I think we need to focus on is the prevention, early intervention element of that, because often unmet need does result in some sort of need in the future, which is often an emergency admission. So I think there's good economics for this as well. I reference in this paper the module that we put in place to look at population health need and to take GP data alongside our data. I think that in itself points to some areas where we could improve our levels of access. You just heard Sarah talk about increasing cancer referrals. We are still encouraging GPs to refer patients as early as possible when with suspected cancer, simply because we get better results for those individuals by finding them earlier. But there's still lots of evidence that shows that quite a big proportion of our cancers show up as emergency tendencies in A&E. So there's a lot of work to be done on this.
Yeah, thanks. I was just interested in whether there was a particular focus and a plan to get into that, but I'll come back to it another time.
I think, Mike, it is a really good challenge, and if we can take it up in a different format, because my worry at the moment is waiting lists are so long that even getting on and meeting the known need, let alone the unmet need, is a challenge for the system. So, but let's come back to that maybe at our round table next month. Callie?
Yes. Thank you. Right. I don't know if in your report my question comes under number 4 or number 11. Deliver. Basically, my issue has to do with discharge integration front runner, and I had personal experience of non-suitable early discharges for advanced cancer patients. And I don't know. I think the communication between that has to do obviously with Walsgrave, and after they discharge patients, these patients didn't get the right community support. Now, it may not have to do with the community teams, it may have to do with Walsgrave, but I know of 2 or 3 cases with patients that have been discharged with no appropriate community support. And I don't know if this area is being audited and it has to do with communications or between different teams or anything along these lines. But I wasn't happy really with the current communication system and the service that the patients received in the community, because if you are discharged with no appropriate community support, and nor you're told is if in trouble call 999, that's no good. And I'm talking about cancer patients that didn't get this service. So I don't know where my question fits, but I just had personal experience, hence the question.
Okay. Thank you, Callie, and I'm sorry you've had that experience. Obviously, we don't run Walsgrave, and therefore the discharge from Walsgrave. But in terms of the general point, Glenn, about the communication support we give, I know that we've obviously got our community recovery service in place, but we haven't had any of that type of negative feedback, have we, on our service?
No, and I think one of the key reasons why that's working so effectively actually is the collaboration that we have with Warwickshire Council on this. And Becky Hale being a joint executive post between the two of us really does make sure we're on the ball on that. I would say, though, that as the provider of all community services across Warwickshire, we also have a responsibility to support patients who are discharged from UHCW back into Warwickshire. But obviously the communication to us needs to be clear for those individual patients into those support pathways. So I would say if there's any more detail you could provide me on that one, I'd be more than happy to have a look at it.
Yeah, thank you. I will do. Thank you.
And Ruth, and then we'll move on.
Mine's just a curiosity question about flexible working. How does it work? Is it more expensive? Who's managing it? What are we drifting into with flexible working? I don't quite understand how flexible it is.
Okay, so where's it all going to end, Ruth? So, I
mean, are we all just going to walk in when we feel like it?
Yeah, I actually had a conversation with the chief executive of a trust elsewhere in the country who had implemented this recently. They went I think it was Maidstone Tunbridge Wells. They went into a any hours contract arrangement with their staff. So basically, we'll employ you. If you want to come and work for us for 5 hours a week or 40 hours a week, we'll make that work. He was a little nervous that could lead to a situation where they can't fulfill their rotas. But actually, it's worked very effectively for them. So the result of being flexible is that you retain people and recruit people. And that's why I suppose that the nervousness about whether you could lose more hours in the short term before you gain those hours of recruitment is why we're doing a few pilots just to test the water on it. I think what you generally find through self-rostering is a willingness to be flexible. If we can respond to individuals' needs at short notice, then there's probably they're more willing to step in and help others and cover each other. And good wards have always worked like that over the years. So I think that kind of putting people in control is what we're trying to achieve. And we'll watch it carefully, but it has been a very positive feedback from staff so far that we're trying to meet those individual needs, because in reality what we've seen over the last few years is people exiting the NHS to go and work for agencies where they can work flexibly.
Thank you, Ruth. Thank you, Glenn. But we are monitoring it very closely, I think, Ruth. You seem to have frozen on my screen. So we'll move on then. Thank you, Glenn, for that overview. We'll come back to you again later. So moving on then to the patient experience assurance report. Ellie, we've obviously had the opportunity to read this. What would you care to pull out?
I just wanted to highlight about the FFT. As you know, we've changed provider, and the result of that has actually been quite astonishing. We've now managed to get 40% response rate, which puts us at the top of the league nationally in terms of our response rate. And A&E, which has always been a challenge, is right up there as well. So that for us is great, because the more feedback we get, the more we understand what we're doing and what we need to do. So I just wanted to highlight that. And you mentioned earlier about our other inquiries for PALS section. Just to say, I've discussed this with the team and we've agreed that that should never be in the top 3 reasons. They've added a couple of extra bits onto the system where they record contacts and complaints to a couple more different subject headings. So hopefully that gives us a bit more detail. So that should never be in the top 3 again.
Thank you, Ellie. Ruth, your hand went up and then went down, and we had a funny emoji come up on screen, which was interesting.
I'm in a bad way. I'll sort it. Sorry.
No worries. So thank you, Ellie. Any questions or perspectives to Ellie on the patient experience assurance report? I'd just like to make a general point for members of the public. I spent with Ellie actually an hour yesterday as maternity safety champion with a group of our midwives, and they were talking about some of the social media that's posted up, some of which is just a bit unkind. I'll just say to members of the public, if you've ever got a concern about the service, reach out to myself or Glenn, but don't be unkind to members of staff who are absolutely doing their best to give you the best experience that they have. There's no need to be uncivil or unkind in one's comments. Thank you, Ellie, for your hard work and your drive. So we'll move on then to the clinical governance assurance report. As I did explain, unfortunately, David Spraggett isn't able to be with us because he's having to come out of retirement and go and be a GP again this afternoon. So I will take the report as read, but invite anyone who'd like to ask a question or give a perspective to do so now, please. Lots of good work going on, I think, on clinical governance, including the follow-up work that we put into the awful situation at the counties of Cheshire and Letby. So lots of assurance being fed into the board on issues such as that, as well as the issues of speaking up more generally. Mary?
Yes, on the July papers, there was a comment about the ward-based pharmacy technicians and the business case not yet being prepared. And I wonder whether there's any progress on that, because that's been discussed now for many months. I don't know what the current situation with that is.
Thank you, Mary. We did actually have a presentation from the head of pharmacy, but Glenn, any update from you?
So the normal process that will go through the planning group and then go up to management board. I've not seen it on the management board agenda, so I can check to see whether it's going through planning group, Mary. So perhaps I can come back to you outside the meeting.
Okay, thank you.
Thank you, Glenn. But there's certainly nothing, and Adam, if you can just come in at this point, please. There's certainly nothing in terms of our process which is delaying that business case. No,
there isn't, Russell. No.
Thank you. So we will move on then to the finance assurance report. This year is sorry, Jean, your hand went up just as I was moving on. Jean?
Yes, sorry, it's just about what Mary just raised. I attend the Safer Discharge group, and it's been months and we haven't had any feedback, and they don't seem to know why we haven't had any feedback. And there seems confusion about whether the business report has actually been submitted or whether it's been prepared. And there seems to be quite a lot of optimism about the fact that we could probably recruit for a technician. I mean, good news that we've actually been able to recruit pharmacists this last month, but it's desperately needed. You know, you could have something waiting in the wings because you're relying on volunteers. I mean, it's really necessary. And they did an audit where they tried it, and it was really successful. So I really don't understand that you don't know, and nobody else seems to know. I raised it with Simon, who tried to find out and said he thought it was because they couldn't recruit anybody. It's confusing.
Okay, we'll get clarity, but there's
Thank you.
The issue is the business case and then the ability to go out and recruit to the business case. What I'm hearing from Adam is the business case hasn't been brought forward, so we'll understand where the business case is. But you know, but based on what Adam said, it hasn't come to management board, so we'll understand where the business case is. At the end of the day, the head of pharmacy needs to put the business case in, otherwise the management board can't look at the business case. Mary?
I just don't want to prolong this. I think that it is with pharmacy to actually prepare the case, and I'm just wondering if it's pressures on pharmacy at the moment that is that means that the senior pharmacists haven't got the capacity to deal with it. That's one of my suggestions, because I think it does lie with pharmacy to.
Okay, let's take that away. But certainly when the head of pharmacy last spoke to the board, it wasn't raised as a problem of them producing a business case. But as Adam's just popped into the chat box, he will follow up with the head of pharmacy and provide any support if they need it. So we'll come back to you before the next Council of Governors meeting, that's for sure. So if we're happy, we'll move on to the finance assurance report. Just before I hand over to Kim, stating the obvious, this is an exceptionally difficult year for all of the reasons around the industrial action and the increase in demand. So we have been proud to be the only acute trust in the Midlands to consistently produce a break-even position. But it will be, this is the most challenging year we've had so far. So with that sort of contextualisation, Kim, over to you.
Thank you, Chair. So just a reminder really for governors, we set a break-even plan as per our statutory duty for this financial year. In order to deliver that, we also set ourselves a cost and productivity improvement plan of £14.5 million, which Glenn's referred to as our Excel in Everything programme. The plan was phased in 12ths, so that's quite ambitious because that's expecting the organisation to deliver straight away in terms of contributing towards those savings targets, but I've deliberately left it in 12ths in order to drive really early identification and delivery to ensure that we hit our plan by the end of the financial year. You'll note, though, in the month 4 report, though, that we are reporting a £2.1 million deficit as per month 4, and that's reflective of the fact that we have slipped against delivery against that CIP kind of target. The other drivers have been to do with continued spend on agency, mainly due to the operational pressures where we've had to open additional capacity that's unplanned for, therefore it's at premium rates. Now we have, worked really hard on our Excel in Everything programme, which is two of the strands is about reducing our medical and nursing agency expenditure. And we've, made some real improvements in terms of increasing our recruitment. So our vacancy targets, vacancy figures have reduced. Our sickness figures have also been improving. And we're just actually now starting to see some sort of reduction in that agency expenditure. But obviously we're still managing the operational pressures where we've seen really high, attendances through ED, and we're also contending with the industrial action as well, which is also impacting on our ability to ensure that everything is safe. So therefore, it does mean that we put in additional resource to ensure that we are safe as an organisation to protect the staff. In terms of the cost improvement target, we have identified £13.4 million of the £14.5 million target. And with the challenges, obviously, for the organisation is to actually deliver that whilst we're managing the operational and industrial action that we're dealing with. We continue to drive our elective performance because that enables us to deliver on our activity and earn our income, which is also really important for us. So we have got mitigations in place in order to ensure we're back on track in terms of delivering on our CIP. Also mitigations to manage some of our cost overspend areas, but also making sure that we are in the best place possible to deliver on the activity to hit our income targets. So we're with those mitigations in place, we still plan to recover the position to deliver a break-even position by the end of the financial year. But as Russell has already outlined, it is challenging, but we're doing the best that we possibly can.
Great summary. Thank you very much, Kim. Questions or perspectives to Kim on the numbers? Jean?
I'm not very good about finance, but do you receive income for patients who attend A&E? And presumably outpatients, it's much more clear line of communication to receive money. But do you receive money from patients who attend from outside the area? Because when we did the recent audit, there was quite a significant number of people who come to Warwick A&E rather than other areas.
I'll try and keep it simple. So we do get money for patients that come in for ED in terms of our ED performance, but it's on a block contract. So it's effectively a fixed element that we get. So despite the amount of attendances that we see through the door, we don't get any more income for it. Now, the only exception is really patients that come from Birmingham and Solihull, where we've negotiated a slightly different contract, which is called payment by results. And that's effectively, we do get paid for what we see for those patients. In terms of our outpatients, we get paid for tariff effectively for every patient that we see for first outpatient appointments, but we don't get the same amount of money for any follow-ups. So that's why our outpatient program, sort of transformation program, is really key in order to make sure that we're delivering the right service for our patients, but at the same time to maximise the income for us as an organisation and ensure that we're reducing any sort of do not attends as well. Did not attends.
You're doing a great job.
Okay, thank you.
Thank you, Jane. And Roger?
A question about the net effect of the industrial action. Are we getting any assistance from the ICB to alleviate against what is obviously going to be an increased pressure on the agency spend in consequence of trying to maintain our elective activity despite the industrial action?
Unfortunately not. We've had indication of how they propose to mitigate financially for the cost of the April strikes only. And we've had early kind of discussions around how they think they're going to manage it on a national basis, where they've got this central pot of money that they've announced that they're effectively using to offset any overspends that we're incurring. That's as much as we know at this point in time, but we're getting limited information on a drip-fed basis, unfortunately, which doesn't help us in terms of our management of our finances. So we're doing whatever we can to try and mitigate that, obviously, because we are a high-performing trust and we do like to ensure that we manage the money.
Yeah, we should assume we don't, Roger, which is what we're assuming.
Yeah.
Bernard?
Okay, thank you.
Yeah, thanks, Kim. Out of curiosity, with no end to the industrial action in immediate sight, as far as I can make out, are you doing any modelling to try and predict as to how much income you're going to lose as a result of all this industrial action? And if so, are you, what are you predicting?
Just before we go into it for a sec, Bernard, it's a double hit. It's not just on the income, it's also on the cost, because we have to obviously cover shifts. But whatever the financial impact is, my primary concern is the citizen impact of the strikes. And that's my greatest concern. But in terms of the finances, Kim, what do we think the strikes in total to date have cost us?
So in terms of our total costs so far, it's about £500,000. So we've been very fortunate that we have not cancelled much activity. So therefore, not had a detrimental impact in terms of the citizens within that we serve. So that's a really positive thing, and we haven't lost a significant amount of income. We did incur some expenditure to backfill, but operationally, the trust and the staff are amazing. They do the best they can to ensure that we're safe, and that's credit really to the operational team and the our clinical teams in order to minimise that expenditure.
Yeah, thank you, Kim. Okay, thank you very much for those questions. Obviously, things aren't easy, but as you've heard, and I think the Excel programme is a really positive momentum that we've built internally to drive the most optimised, as I'm using that phrase, given the situation that we are in at the moment with the industrial action. Thank you, Kim. We'll move on then to the audit assurance report. Richard, what would you care to pull out of these?
Well, there's 3 meetings we've got in there which go through which could be taken as read. I think somebody asked for some update on the audit, which is the last page of my report. I'm really pleased to confirm that this year, unlike last year where we were well beyond the normal deadlines, we achieved the delivery of the accounts by 30th of June, and they were filed in Parliament before the parliamentary recess. And really thanks to Kim and her team, Sue Munn, who's the Deputy Trust Secretary, who picked up doing the annual report, which was done nice and early, and Deloitte actually did come towards the end. There were issues, there are always issues because there's so much to do, and every year the number of items that need to be reported seems to go up and up and up, but it was well handled. In terms of other trusts, we were probably an exception actually achieving the deadline. There were many other trusts, even in the foundation group, that didn't achieve the 30th of June deadline. So I think credit to all. One of the issues with auditors for public bodies, there's quite a limited market for it. We went out for a market testing from an award of the contract from April 21 to March 2025. It was only Deloitte and one other firm that were prepared to quote. There was quite a small pool. And we have to exclude PwC, who advise us in non-audit matters. So that's one of the players out in the marketplace as well. Generally, there's going to be a debrief with lessons learnt. I think we spread the issues, all the concerns out in a wider base, so things were dealt with in a timely manner. But again, I think one of the issues we've got is with Deloitte, some of their junior staff don't really understand what they're asking for and what they've been doing. So it's only towards the end do they have a sanity check and actually say, this is actually what you're asking for, and this is the way we can do it. But generally it worked well, and daily calls between Kim and in-house, the Deloitte's partner, made sure we delivered on time. And I didn't go into too much detail with Deloitte. I just kept the drumbeat, 30th of June, no excuses, and left it to them, rather than getting me sidetracked. That was the prime thing.
Thank you, Richard. Any questions or perspectives to Richard on the audit assurance report? Kelly?
Sorry, I don't know if that's a technical question. Somewhere in your report, you talked about journal reconciliations. I don't know if that has to do with accountancy terms. Just asking what a journal reconciliation is.
Making sure things add up, as simple as Kelly.
As simple as that. So it's just an accountancy term, or.
But it's Richard. Do you want to say anything?
Yeah, reconciliation means that there is obviously control totals for all the accounts, which is the total summary of everything. But then you need to go in and actually check all the individual items add up to the total. There's no corruption in the data, basically.
All right. Okay. And right, the KPIs, are these set by NHS England, or are they set by central government or whatever? The KPIs.
We obviously talk about that with the Council of Governors, don't we, Kelly? So we have some of the KPIs are nationally set, and then we have some locally set, and we discuss those with the Council of Governors at those meetings.
Okay, thank you.
Okay, team, just conscious of the need to keep things moving. So we therefore move on to the reports from representatives on project groups. If I can ask the Governor colleagues to assume we've read the reports, so just pull out any key points. First up is the Ellen Badger Hospital Site Redevelopment Update Report. Mike?
Thank you, Russell. Yeah, the report's been circulated. There has been a project board. It was actually last Wednesday, and I checked with Mary Powell, and nothing of any great significance came up. The building work's just getting on, really. So there isn't anything. I think the only interesting thing is Sophie's been talking to Andrew Revel from Shipston Home Nursing, who do palliative care at home, about working more closely together, which should be interesting.
Thank you, Mike. Thank you for the perseverance, energy, and positive energy through all of this journey. Questions and perspectives to Mike. Roger?
Just a quick one. With the bed review having been kicked into the middle of next year's long grass, does this actually slow down the construction, or would it still be constructed regardless of what the answer on the bed review is?
Yes, it is problematic. Glenn, do you want to come in on that, please?
Yeah, I'm sure Mike could answer this one as well, actually, but no, it's not. So we've got a design for the site that would allow beds to be built in a zone if that was deemed to be the right thing to do, which obviously we do not feel it is. Notwithstanding that, the construction of the build that we've gone public on will progress. So that will be open next summer.
Yeah, excellent. Thank you, Glenn. Thank you, Mike. We'll move on then to the End of Life Committee update report. Michael, what would you care to pull out of this?
Sorry, I think it speaks for itself. The things that really are arising, and which you have emphasised, are the importance of end of life. It isn't, and I think the thing that I would hope is coming across is this isn't the last few days. End of life, recognised as soon as possible, and then obviously things geared to ensure that the people are as happy as is possible, and not only them, but of course the people who they're engaged with, because death affects not only the person who dies, but obviously all of the family and so forth. And there is a general feeling in the committee, as an outsider, because I'm an observer, there is an enthusiasm which I think is terribly important, particularly in fact from the leaders. I have set out that example where they, if you like, deconstructed one particular gentleman's end of life few days, and shows there that the need for instance, the paperwork to be either well known to staff or easier, whichever can be attained, because there, fortunately, someone recognised that the staff were having difficulty, overcame that difficulty, and the object was to get him home. And actually, because they'd recognised the problem, they did get him home, but actually only by 2 days. And you could imagine the difference there might have been. I understand that they are looking, in fact, for further assistance, and I would trust that that will be forthcoming. I think there's a new business case coming forward, and I hope the directors will be helpful.
Yeah, no, I know end of life services are a key focus for us. As I said, it's important to allow life to leave dignity in the world, and that's one of our key areas. Any questions to Michael? Callie? If you're talking, Callie, we can't hear you.
Thanks, Michael. My question, somewhere in your report, you're talking about a push towards online palliative care. What that means, online palliative care. I do understand that you can have as a staff member or a volunteer online training, but what is online palliative care? Because I've been involved in palliative care recently, and you need face-to-face interaction, as simple as that. So I think that means.
I think that's about training the staff, isn't it, Michael?
Okay.
Yes, that's training the staff.
Okay.
Yeah.
Which is a very important feature.
Yeah. And obviously all these programs are highly accredited, etc. The training that the staff receive. I mean, because palliative care is a very sensitive area anyway. So that's why I'm asking. So
yeah, no, absolutely, Callie.
I think the major factor is we all look to go to hospital to get better, and obviously the staff are there to get us better. Death is inevitable in some cases, and the difficulty is if you like, getting people interested in death as against their main concern, which is life.
Yeah, absolutely. They're very important conversations which we've been involved in at the forefront of, to be honest, I think for a number of years. And I'd just like to put on record my thanks to our chaplaincy services, because they play a very important role in helping our end of life teams and families and individuals at the end of life on spiritual matters or issues of faith, which I know are very important. So thank you to all of our chaplaincy team for their support. We'll move on now to the Falls Prevention Steering Group update. Again, we'll take the report as read. David, anything you'd like to add? David, if you're talking, we can't hear you. Okay, still can't hear David.
That should do it.
Yeah.
Can you hear me now?
Can hear you now, David. Anything you'd like to add to your report?
Right, thank you. Sorry about the muddled layout of this. The meeting was cancelled, a very short meeting, but I had previously presented this email that I received from the Stroke Association. I had presented the message at the previous Falls meeting for consideration, as I had concerns that services could be overlapping and the two services were not working together to the best for patients, but we'll now have to wait till the next meeting until I get the feedback. In the meantime, I have asked the Stroke Association for more information on what extra services they can now provide, but have heard nothing further, which is rather disappointing.
Okay, well, David, if I can help in any regard, just reach out to me. Any questions to David on the Falls Prevention Steering Group update? Thank you, David, for your diligence then. So we'll move on then to the Patient Experience Group update. Sharon? Sorry, Sharon, we can't hear you.
Sorry, Russell, I didn't realise I was actually on the agenda to give an update on.
The Patient Experience Group update.
Oh, right, I've got the
We can
report.
take.
Yeah,
we
I've
can
got the
take-
report typed up, and I can send it over and add it to the minutes. Is that all right?
That's fine. We actually have a report in the pack, but
Yeah,
it's
that's
just
the one I did.
whether you want to add anything to it or just take it as read.
No, take it as read, please. Thank you.
No, that's our pleasure. Any questions to Sharon on the Patient Experience Group update? Thank you, Sharon, and thank you for all your hard work with all of the volunteers. And we then move on to the Patient Safety Surveillance Committee update report, brackets meeting postponed until 29th of September, my birthday, just for those of you who maybe have forgotten. So there's no report. Sue, I assume we'll wait until the next Council of Governors meeting to hear from you then.
If I could just say very briefly that there's been a lot of the last few meetings have been cancelled, postponed, because this is quite a big change in the way that we investigate incidents, and moving to the patient safety incident response framework. So it's going to be a more effective way, I think, of doing it, but there's a massive amount of work. So there is a meeting in September just to look at how we take it forward.
I think what would be useful for governors is to get, and Glenn, if you and I can take this away with Sarah, is to think about how we do get you trained on PSURF, because it is a different way of looking at patient safety incidents, and it's far more focused on learning. So we'll take that away and maybe take input from you as well, Sue, if that's okay.
Yeah, could I just say that we spoke to Fiona at the Patient Care Committee, and there's big benefits in actually saving time, because looking at incidents rather than doing a root cause analysis on every incident, we can be grouping incidents that are very similar and just do a deep dive root cause analysis on one or two of them and learn from those.
But I think all governors would be interested in understanding that the way nationally there's a change in the way we're looking at patient safety incidents. So we'll take that away and make sure a briefing notice is produced. Thank you, Sue. So move on then to the Patient Portal Focus Group update. And Pat, that meeting was cancelled, I understand?
Yes, the meeting was cancelled, and the reason was that there's been some more funding the trust has recently acquired some new funding, and there's a new project manager and a business change resource, and they were commencing in September. And in the circumstances, it was felt better to wait until the next Council of Governors meeting in November, when a patient portal forum meeting should have taken place and an up-to-date report can be presented. And I will keep my eye on this.
No, thank you very much.
So that's the situation.
Thank you, Pat. Adam, I am correct in saying that the patient portal in terms of sign up and use has turned out to be far more popular than we frankly ever imagined. Is that correct still?
Absolutely, yes. It's got really good take up, Russell, and a lot of development work ongoing.
Yeah, that's super. Thank you. Okay, keep us briefed, please, Pat. So we'll move on then to the Safer Discharge Group. Jane, anything you'd like to pull out of your report?
Just to say congratulations to the Emergency Division team on their national award. The discharge team manager, as I've written, said it was down to the work of the volunteers, which I think we need to make sure that all the governors are aware. There's also, we've already talked about the business case and the pharmacy technician, and criteria-led discharge is being commenced, and on some of the wards it's really good. What is impressive is many of the wards, when there's the strike on or when there's other difficulties, prepare a case and prepare the discharge prior to the weekend, so that if the patient is then discharged at the weekend, they've got everything in hand. And I also like to say that the Safer Discharge Group, they meet every other month, but it really is rigorous and they really go into a lot of detail, and everybody present works really hard to try and keep abreast and ahead of the numbers of admissions and discharges. So I think they need congratulation and saying thank you.
No, thank you very much, June, and the community recovery team are fantastic at that. Questions and perspectives, Roger?
Just a brief one on the respect form. There's suggestion in the last bullet point that there should always be a respect form for the patient. But in the recent chief meeting by Kate Hubble, consultant on end of life, that a respect form should be considered but not mandated. It depends on the patient's and the patient's carer's wishes. This seems to be going slightly contrary to that.
The nurses wouldn't agree with what you've just stated. They're striving to make sure there's a new one, even if it's the same as the old one, so that there's a date and they can confirm it has been reviewed. And great strides, a lot of work is put in to making sure that that's, oh, for goodness sake.
That's okay, Jane. I think that there is, I'll bring Emma in because Emma will have an interesting perspective. Emma?
Hi, thank you. Yeah, I think that the discussion around respect form is the thing. And if the individual and their family and the team around them feel that they don't want a respect form, then that is kind of their choice. It's part of their choice. So it's been addressed, it's been, and they're almost kind of handing over then, so that the professionals who are treating them at that given time, if they call for help, will decide what's best for them at the time, as opposed to them getting the choice.
That's exactly right, Emma. Exactly. Thank you. Which is why I wanted to bring you in for that clarification. Callie?
Thanks, Jean. I just wonder, I read the bit about criteria-led discharge, and I don't know, obviously, can you, I don't know, explain a little bit more? Is it a different wards do their own thing, and how are these criteria-led discharges are being established? Is it something that each ward or each department sets and then the clinicians need to follow? How does it work?
So, Jean, can I suggest Ellie answers that rather than
yes,
you?
Please.
Yeah. Ellie? Have I lost
Well,
Ellie?
just repeat that. I'm having some technical issues and they keep freezing.
No worries. So, Ellie, in terms of the criteria-based discharges, the question from Callie was, do different wards have different criteria, or are there a common set of criteria?
They're individualised to the patient, so each patient would have specific criteria they need to meet to be safely discharged, and the consultant and the team as a multidisciplinary team, because it's not just about their medical fitness, it's about their ability to manage will agree when they can meet those criteria, they can be discharged without the consultant present. So it's individualised.
Yeah, very personalised.
I don't want to keep you too long, but if a patient says that the department wants to discharge the patient and the patient says, sorry, I don't feel well to go because I can't breathe well or whatever else, and sometimes the clinician says, oh, your vital signs are fine, you can go home. Is it the consultant's final decision, obviously, to discharge the patient, even if the patient says, I don't feel well to go home? How does it work? It's the consultant's final decision. Is that it? So
it is difficult, Callie, to be honest. I mean, we don't throw people out the door and lock the door behind them. So there needs to be, an appropriate conversation to, if the patient's anxious about going home, there will be appropriate conversations about why they're anxious to go home. And if they're concerned about an aspect of their health, there'll be appropriate conversations. But we don't throw people out of the hospital. Very, very rarely you do get people who refuse to leave. But that is under very rare circumstances, and I don't think you're asking that question. I'm correct in what I've just said, aren't I, Ellie?
Yeah, absolutely. I think the first thing we do is try and understand why they're anxious about going home.
Yeah. And Michael, then we'll move on.
Sorry, just reverting to the respect form. I don't want to enter into it here, but I would hope that that would be referred to Dr. Kate Hallett, who has very clear views on this and is very much aware of it.
Yeah, I think as Ellie's indicated, and sorry, as apologies, I'm having a brain blank. Emma indicated, we absolutely do ensure we have discussions about a respect form, but if people don't want to fill out a respect form, then clearly we can't force people to fill out a respect form. But what we do ensure is that we have a discussion about the respect form. That's correct, isn't it, Emma?
Absolutely. There's even a little leaflet that we can leave with them that they can have a little read of if they want to. Yeah.
Thank you.
That leaves me happy.
Thank you, Michael. Need to pick up the pace a bit, team, because we lose Glenn, unfortunately, at 4 o'clock, and I want us to have heard Glenn in the confidential section before then. So the wayfinding project update. Roger, anything you want to add to your report?
No, other than to say all efforts are being made to make sure that patients can find their way around, but with the construction clearance and everything else moving apace, it's not easy to get it all done within 24 hours. But efforts are being made to keep up with the pace of the elective hub work.
Yeah, no, absolutely. And I'd just like to thank the communications team, because I see an awful lot of updates on Facebook and social media, so I know they are doing their best. But for members of the public who don't use social media, it's an issue to understand all the changes that are going on. So thank you. Any questions to Roger? Michael, your hand is still up. I assume that's a legacy hand. Any other questions to Roger on wayfinding? Okay, thank you. So we'll move on then to the elective care group update. Graham, anything you would like to add to your report, which will take as read?
No, there's the report is very detailed, excellent report produced by Mark Jones. I think the only comment I've got is that it's a very well run project. I've been on a number of project boards. This one is excellent. And they seem to be tackling the risks and notifying the risks. Now, in the annual general meeting this morning, you did mention, I think it was Glenn mentioned about the crumbly concrete and possibly reducing the amount of capital available. They've now marked that down as a risk as we go forward, and also some of the increase in costs. So yeah, they're very, very clear, and Kim's on the call, she sits on the board about the finances. But other than that, all I can say is a very well run project.
Oh, that's great. Thank you for that feedback, Graham. We'll ensure the teams hear that. Any questions or perspectives to Graham or his report? Thank you, Graham. So we'll move on then to the Radiation Protection Committee update report. Carolyn, anything you'd like to add to your report?
Yeah, I'd like to say that this is my first time, I'm assuming you're hearing me and not too much echo. My first time at that committee, so I'm not very familiar with the terms and activities nor with the people, so I've done my best. The next meeting is November, so I'll probably get a better report by then because I'll be more familiar. No, not really, unless anyone's got questions, but I can't guarantee to be able to answer them very fully, but I'll do my best.
Story of my life, Carolyn, not being able to answer every question. Any questions or perspectives to Carolyn? Okay, thank you, Carolyn, for volunteering. Yeah, you've escaped. Won't be the same in November, be loads of questions.
Yeah.
So we'll move on then to the Salix Project Board update report. John?
Can't hear you, Russell.
We may have lost John, so we'll move on then to the Community Diagnostic Centre Project Board report. Mike, anything you'd like to brief us on?
Yes, Russell. Like Carolyn, I'm new to this one. I only got into it last week, and I've been a little busy since. So I apologise for the verbal report, but I do have a couple of paragraphs I'd like to just read out, which I can then add to the minutes if that's okay with you.
Thank you.
Yeah. The project is being managed by Jane Blackley for the Trust and Swift Clinical Services. I had an initial briefing session last week with Jane, and she explained the development of the preferred option, which is shown in the planning application to the District Council. She set out how the proposed location fits with the current use of Building 1, and that the future design, redesign and potential strategic site development control plan for the hospital would benefit from it being there. The use of temporary buildings for the CDC, which is common to many of the projects nationally, and I've seen those elsewhere, has been discarded in favour of a permanent strategic solution, which provides the best fit for the next phase of the Stratford site development. The new accommodation will support the provision of radiology services such as CT, ultrasound, and additional permanent MRI, respiratory function testing, and cardiac testing. We talked about the procurement process, the design layout, the impact on the other services on site, and in particular the car parking provision, which Stratford governors are very keen on. The business case is being developed by a small group of trust staff, including finance, operational leads, project technical advisors. The business case will include the full mobilisation plan, which will be of interest to governors. And the current plan is that the business case will go to the Swift Clinical Services and Trust Boards in December. And if approved, the formal project board will then be set up and the scheme mobilised in January 24, having been tendered already by then. I need to add, if the scheme is not progressed, the Trust will lose the £6 million funding. And I can also report that the Trust is having some initial conversations with Stratford District Council on the potential for some construction, some community infrastructure levy or Section 106 added funding, which is something we'll need to follow through. I'll have further briefing sessions with Jane in October and November, and we'll join the formal project board when it commences. Thank you.
Thank you very much, Mike, and thank you for volunteering, and we'll make sure that's all added up onto the minutes. Any questions to Mike on what you've heard, Roger?
Just a brief one. The planning consultants have got themselves muddled as to which is Building 1 and Building 2. They've called the new building Building 1. So be aware that, that there is a muddle in both the application and the briefing you've just given us, because that's driven from the planning.
Okay, thank you very much, Roger. Any other questions to Mike? Okay, we'll move on then, and if I can, under the governance matter in the minutes, basically take the minutes as read and just ask questions. So the Patient Care Committee minutes for the meetings held on the 22nd of May, 19th of June, 10th of July and the 14th of August, 30 pages in total. Jean, I assume there's nothing you want to add. Any questions on those minutes? Please raise a digital hand. Okay, thank you, Jean, for your work on that committee. The General Purposes Committee draft minutes for the meeting held on the 13th of July. Mary, is there anything you want to add to those?
Not really, just as a take as read. It was business as usual, but included the round table this time. And the committee agreed the arrangements for the new membership and engagement committee, which is on the agenda later, with the chair as Mike Flaxman. John Egan was approved as the governor on the SALEX project board, and Mike Flaxman as the governor on the Community Diagnostic Hub, as we've just heard.
Yeah.
And after the meeting, arrangements was circulated to all governors on the protocol for visits to wards and departments. I just hope that all members have received that and noted it. But that's all. Thank you, Russell.
Okay, super. Any questions to Mary on the GPC minutes? Thank you, Mary, for chairing that. And the Membership and Engagement Committee draft minutes of the 14th of August. Mike, I'll take as read unless there's anything you want to add.
I just want to add my thanks to Mary and Roger, who are not members of that subcommittee, but came along to fill us in on the past history of what had happened on membership and engagement. So
Okay,
thank you.
Thank you, Mike. Any questions to Mike? Okay, and so we'll move on then to the updated Register of Governors and Register of Governors' Interests. Sarah.
Terms of reference to go back to.
I apologise, Mike. So the Membership and Engagement Committee terms of reference, which will take as read. Any questions on those terms of reference? Okay, if you're not happy to approve them, could you please raise a digital hand? Super, approved. Thank you, Mike. You've got full authority now.
Thank you so much.
So we'll then move on to the updated Register of Governors and Register of Governors' Interests. Sarah, anything you'd like to add to this?
I have to take it as read, Russell. Thank you.
Okay, I assume there are no further amendments. If there are any further amendments from governors, could you please raise a digital hand? Okay, great, super. So they are duly noted. Then we're on to the report on resignation and appointment of governors. Sarah, back over to you.
Yeah, also happy for this to be taken as read. Thanks, Russell.
Okay, thank you. Any questions from colleagues? Okay, we'll move on then to the reappointment of the Trust Chair. Roger, we'll take the paper as read, but anything you want to add?
No, thank you. The reasoning behind it is quite complex, but I'm taking that every governor has had the opportunity of reading carefully through it. The reasons are set out there. I've got nothing further to add.
Any questions from colleagues on the reappointment of the Trust Chair? Please raise a digital hand. Okay, no digital hands being raised. Thank you, Roger. So the appointment of Associate Non-Executive Directors. Roger, back with you.
I think, Russell, we have to actually approve. We have to approve your reappointment.
Okay, apologies. I've just got it as information on mine. I apologise, Roger. If you're not happy to approve my reappointment, I'll close my eyes. Could you please raise a digital hand? Okay, duly approved. Thank you very much for the confidence and support of all of the governors until my role as Trust Chair. We then move on to the appointment of Associate Non-Executive Directors. Again, over to you, Roger.
Straightforward. the recruitment went out with the idea of selecting 2 associate non-execs, but we found 3 excellent candidates and couldn't split between them. So the answer was, we'll recruit 3, please. So again, this is for a formal decision.
Okay, so thank you, Roger, for your support and other governors. It wasn't the smoothest of processes, but I think we've ended up with 3 outstanding candidates, 2 of whom I know are on the line today. Any questions from colleagues about the appointment of the associate NEDs? Mike?
It's just a small comment in terms of presentation of the report. I would have found it immensely helpful to just have had a sentence or 2 about each of the people being nominated as appointees. I'm sure that Roger and his committee made a very, very sensible and very thorough decision, and there's no way that I will object to it. But it would have just been useful to have had a sentence or 2 rather than just seeing their names on the piece of paper.
I think that's a fair challenge, Mike, and I'm sure that the CVs of the 3 individuals are circulated to all the governors. But at its simplest, Barty is a very experienced ex-pharmacist, commercial pharmacist, involved in very senior global procurement roles. Oliver Collier, I'd have to say it's Oliver and Ollie. Oliver Collier has been a senior executive within Cadbury's and their holding company for a number of years. And Ollie Hisco has done an awful lot in the voluntary and community sector. So 3 outstanding candidates, but we will circulate their CVs. Thank you.
Can I apologise in advance for the potential confusion by being so bold as to select 2 people with the name of Oliver, notwithstanding that Ollie wishes to be known in that way.
Yeah, no, thank you, Roger. So just for confirmation, if you're not happy to appoint, please raise a digital hand. Duly appointed. Barty, Oliver and Ollie, you can no longer escape. Welcome to the team. Thank you. And then we'll move on to the chair and vice chair remuneration review. Roger, over to you.
Again, straightforward, in line with the various guidance issued by NHSE. I think, in fact, we stray slightly beyond the medium-sized trust into large trust, right at the bottom of that, from what Kim has reported earlier on, but straightforward, following the guidance, and there's absolutely no reason why we should deviate from it. So I recommend that the committee recommends that we go forward in this way. Again, for formal approval.
No, thank you, Roger. And just for clarity, even though I'm being paid a little bit more for taking on Worcester, the cost to Swift remains at 33,000 for my role. Any questions on the chair and vice chair remuneration review? If you're not happy to approve those, could you please raise a digital hand? Okay, thank you. Duly approved. We've then got the external auditor's annual report for 22-23. Have we got colleagues from Deloitte with us?
Yes. Hi, Russell.
Hi. I heard a hi, but I can't see you. But thank you for joining us. So over to you, Chris. Or Ian, what would you care to pull out?
So I think the key things to draw out are that all the opinions were signed by the deadline and they were all unmodified, which is obviously incredibly important. And as Richard said earlier, that wasn't the case across the country. So that just shows just how well things went. I would echo Kim and Russell's comments earlier about the challenges for this financial year. This isn't obviously just the trust, but this is across the system and nationally. And then just finally, a massive thank you to Kim and to her team for their effort in working with us during the audits, which can be painful at times.
Chris, thank you for your hard work, and can you thank the rest of your team? I know it's very, very busy for you generally. We do appreciate your partnership with us. Any questions from colleagues to Chris? Okay, duly noted, Chris. Thank you. Look forward to working with you again. You take care. Hope you've had a good summer. So we're then on to any other business. Any other business, please raise a digital hand. Any questions from governors in this public session? Otherwise, we will move into the confidential session. David?
Yes, thank you. If I could read this out, please. In the last 4 weeks, I've had to attend the Strike Stratford MIU twice and Warwick twice when Stratford is not open. My last visit was to Stratford MIU Tuesday week ago to find that it was packed with even the waiting room full. In the end, I had to wait nearly 3 hours before being seen, even though it was fully staffed with 2 nurses on duty. The nurse explained that Tuesdays are always very busy due to the 4-day gap between openings. If necessary, in the meantime, people like myself have to go for Warwick for help, increasing the pressure on Warwick. To reduce this pressure on Warwick, could not Stratford be open Monday, Wednesday and Fridays, reducing these gaps to just 2 days?
Thank you, David. As you know, when we opened up the Stratford MIU, we were all concerned about the ability for it to be sustainable, given the increased demand that we were seeing even then at Warwick A&D, and the need to ensure that Warwick A&D is safe. But Glenn, what do you think the potential is for us to expand the opening days of Stratford MIU?
Yeah, just to give you an indication of the numbers, that Stratford is around about 30 to 40 patients per day when it's open. Warwick sees about 250, 300 patients per day, roughly. The reason why we have not opened Stratford fully throughout the week, as we indeed were prior to COVID, is because we still have some acute staffing issues in the main department, and the opening over 5 days would have pulled staff away from the main department. But we continue to review that. We've just agreed a new business case for the main department. Our recruitment, as I mentioned earlier, is getting into a better place. So that's something we could come back to at the right point.
Yeah, no, thank you, Glenn. Our priority needs to be the safety of Warwick A&D. David, your hand is still up. Did you want to make another point?
I was not saying to increase, I was saying to rearrange to Monday, Wednesday and Friday.
But you need to staff it.
Each end.
Yeah, but you need to staff it, David, don't you, on the Wednesday? We don't just employ people on those 2 days, we employ them on every day, and we allocate them to that. So it would require an increase in staffing. And I think that was what Glenn is saying. We're trying to recruit staff. Recruiting staff into A&D is exceedingly difficult at the moment. Glenn, anything you'd like further to add?
Yeah, I mean, it's based on the working patterns of individual team members, David. But we, as I say, we will keep reviewing it, because if we, obviously, it doesn't have the same functionality as Warwick, so it's not always the case that people can go to Stratford. But if we could meet demand there to take the burden away from Warwick, then we would do it.
Yeah, and I would say to members of the public, if you're thinking of going to the Stratford Minor Injuries Unit or the A&D, can you just reflect on whether there are other places you could go? You know, as an example, if you've been stung by a bee, you could go to your pharmacy for support there. There are sometimes other routes to free up the demand that we are seeing into the Stratford MIU and to the Warwick A&D. And if you can help us, it allows us to help you. If there is no any other business, are there any members of the public who want to ask any other questions? Please raise a digital hand. Okay, just two quick things for me then. The first is we've had a request for a while from members of the governors to try and get back into more face-to-face meetings. And therefore, one of the things I want to happen next year is that our round table meetings from next year onwards, i.e. calendar 24, will be physical face-to-face meetings. So we will be going back to some physical face-to-face meetings. And the second thing I wanted to say was an enormous vote of thanks to Sarah Jane, this is her last meeting with us as the support to the Council of Governors. Sarah Jane, I know you've made a real impact with governors, and I'd just like to thank you on behalf of the whole council for your work. Jane, you've put your hand up again. I'm trying to get us to confidential board before Glenn has to leave us, but Jane?
Okay, very quickly, I just wondered if you're going to have enough staff for all the new buildings when they're finished.
Certainly hope so, Jane. Otherwise, we've really shot ourselves in the foot. Glenn?
Yes, in summary, I mean, a lot of the work that we're doing at the moment is to move the urology ward into a more purpose-built facility with a bit more space. So there's a marginal recruitment alongside that. The bigger plan around theatre expansion is obviously something that we'll come back to. One of the reasons why we've gone for a vanguard theatre to help us with elective capacity this year is because it does come with theatre staff, and therefore we just supply the surgeons and anaesthetists. So we're carefully looking at that, but as I say, it's an improving picture on recruitment generally.
Okay, thank you, Glenn. And Mary's just added her thanks, Sarah Jane, saying the invaluable help you've given her as lead governor. So you will be greatly missed. Ladies and gentlemen, that brings our public meeting to a close. Can I ask governors to therefore jump into the confidential meeting so that we can get going on that? In the meantime, take care, everyone, and look forward to seeing you at the next Council of Governors or the next board meeting. Take care.